Hi, this is David Desert of Pancanology. I'm a retired engineer and an 11-year pancreatic cancer survivor. In this video, I'll be discussing tumors at the head of your pancreas. What does that mean? And what are the implications for symptoms, treatment, and prognosis? So, a few disclaimers. I'm not a doctor. Talk to your doctor. My drawings are not exact. And check the video description for my sources. Here's the pancreas as seen looking at the front of a person. Let's add a few nearby organs. We've got the liver above and the spleen to the right, plus a few arteries and veins. The NCCN treatment guidelines, which I strongly encourage everyone to get for themselves, points to this other document that attempts to standardize reports on pancreatic tumors. It's in here that the tumor locations of the head, uncinate process, body, and tail are defined. Tumors at the head of the pancreas are located to the patient's right of the superior mesenteric vein. According to the SEER National Cancer Database, about 2/3 of pancreatic cancer patients are diagnosed with head tumors. Tumors at the uncinate process are also located to the right of the superior mesenteric vein, but within this lower hook-like area that I'm showing here. Let's also quickly look at where the body and tail tumors would be located. Tumors at the head of the pancreas usually cause symptoms earlier and at smaller sizes than elsewhere in the pancreas. On this side of the pancreas, there are more structures for the tumor to infiltrate, forcing doctors to take notice. Head tumors often block the duct carrying bile from the liver and gallbladder, leading to jaundice, dark urine, and light-colored stools. People with jaundice are hard for doctors to dismiss, encouraging imaging of the area that can discover a tumor weeks earlier than those with just back pain. A head tumor may also block the pancreatic duct that normally brings enzymes into the GI tract. Common symptoms will include weight loss, diarrhea, and pain, especially after meals. Tumors in this area may also compress the stomach, leading to weight loss, nausea and vomiting, and abdominal pains. The duodenum, which cradles the head of the pancreas, can also be compressed, leading to the same symptoms. Most articles I found on this topic reference a 1992 textbook listing these symptoms. I've added some possible causes and treatments you might bring up with your doctor. Currently, we have two top standard treatments. One of the treatments is FOLFIRINOX. It's a combination of 4 different drugs that make up the name. Of importance to head tumors is the increased toxicity of irinotecan when the bile duct is blocked, causing high bilirubin. The FOLFIRINOX Phase 3 clinical trial in 2011 underrepresented head tumors, possibly because they excluded people with high bilirubin due to the toxicity risk. There were no significant differences in survival for head versus body or tail tumors. The other top treatment is a combination of gemcitabine and Abraxane, which was FDA approved in 2013. The gemcitabine-Abraxane trial slightly, but not significantly, favored head tumors, both survival and disease progression, as compared to tail tumors. In a longer look at survival, the slight head tumor advantage still held. Sometimes radiation is used to try and shrink the tumor before attempting surgery, hopefully resulting in an easier resection. The two most common types of radiation are IMRT, which is a lower intensity but over a longer period of time, and SBRT, which is higher intensity over a shorter period of time. The duodenum that cradles the head of the pancreas is sensitive to intense radiation. Tumors at the pancreas head are more often treated with the month of lower dose IMRT radiation instead of the 1-week high dose SBRT radiation. In order to reduce the risk of ulcers, some radiologists will preventatively prescribe PPIs. The NCCN guidelines contain a section on the criteria defining resectability status for pancreatic cancer. When the tumor is at the pancreas head, a Whipple procedure is performed. There are several criteria about tumor involvement with the blood vessels before allowing surgery. The celiac axis is a short artery segment that originates at the aorta and branches out to the hepatic artery and the liver, the gastroduodenal artery to the stomach and duodenum, and the splenic artery to the spleen. To allow surgery, both the aorta and the celiac axis need to be freed from any tumor. The SMA also originates from the aorta, passing between the pancreas body and uncinate process to supply blood for the large and small intestines. Before surgery, it needs to be clear of the tumor. The SMV returns nutrient-rich blood from the large and small intestines, passing between the pancreas body and uncinate process and into the liver. There's a little more leeway of tumor involvement for veins. A tumor should not wrap more than halfway around this vein. And if that wasn't enough, the largest vein in your body, the inferior vena cava, also passes by the head of the pancreas, bringing blood back from your lower body to the heart. With this table, I try to summarize the 2021 NCCN resectability criteria, albeit in a greatly simplified format that does not catch all the nuances of the NCCN table. A review of the overall survival studies is mostly consistent about survival differences. Patients with head tumors survive longer because of earlier diagnosis, less frequent metastases, and being eligible for surgical resection more often. However, body and tail tumors having surgery enjoy longer survival times. This may be because of the difficulty and complications of a Whipple surgery. Seeking out the most experienced surgeons and hospitals for the Whipple really makes sense. A pancreatic head tumor can be caught earlier due to a quicker onset of symptoms. Certain symptoms and treatments are more likely with head tumors. If you meet certain criteria, a Whipple procedure can be performed in an attempt to cure, but that surgery is very complicated, and you are strongly encouraged to seek out the most experienced surgeons for the best outcomes. My hope is that you found something here to discuss with your doctors. I feel that the more you understand something, the better you can deal with it.